This is Nicole Asbury, and I'll be completing a dry run of the in-service that I'm going to be offering to my staff on April the 14th for the change project that I have been working on this semester of early and frequent patient ambulation. Upon completion of my in-service, my staff will be able to describe the criteria for medical stability, assess patients' ability to be ambulated out of bed or to a chair using this criteria, and they will be able to identify and designate the signage that we'll be using to communicate to all staff the patient's ability to bear weight and get out of bed. The exclusion criteria for patients who will not be allowed to ambulate are the criteria that we're going to be going over. This will be the main foundation for the patients that we're going to decide. This criteria includes unstable angina, resting systolic blood pressure greater than 200, or a diastolic blood pressure greater than 110, comatose or unresponsive patients, multifocal premature ventricular contractions or PVCs, or more than 10 PVCs in 1 minute while at rest, new onset atrial fibrillation or AFib, uncontrolled heart failure, patients who are on more than one vasopressor, aneurysms that are suspected or known to have ruptured, or patients who are on high amounts of oxygen, greater than 70%, acute systemic illnesses such as sepsis or septic shock, and fevers. This is expected to take 3 minutes of my time. I'm going to go over this criteria with my staff, see any feedback that they have. I'm going to accommodate my staff's the methodologies that I'll be using for this will include a handout for visual learners, which I submitted for approval. Continuing through my in-service, I do have some examples that I'm going to provide my staff about whether they're going to be able to properly assess our patients. The first example I have is a 50-year-old patient admitted 3 days ago with hypertension. Their blood pressure on admission was 205 over 100. When they were admitted, they were on 150 mics of nitro, but they're currently on 50 mics of nitro. No chest pain or shortness of breath, and their blood pressure is currently 150 over 92. They're compliant with their medication while they've been admitted. So I'm going to ask my staff, are we going to allow this patient out of bed? Hopefully, based on the criteria that they've been provided, they will answer that this patient will be allowed out of bed to ambulate. However, if they're unable to tolerate the ambulation, we're still going to allow them out of bed, even to a chair. If they prefer to sit in a chair for their meals or watch the TV, we will allow them out of bed. However, if they become tachycardic or increase hypertension while they're in the chair, we may have to put them back in the bed and wait on further recommendation from the cardiologist. My second example is a 72-year-old patient who was admitted with new onset AFib. They're now on a controlled rate of 90, and they're currently only on 5 mics of cardizem. They're tolerating it well, and they have a planned cardioversion in the morning. Are we going to allow this patient out of bed? Again, based on the criteria that I provided my staff and the education that I'll provide them in coming days, no, this patient will not be allowed out of bed. They are a new onset AFib, and we have a lot of education to go over with them concerning the blood thinners that they'll be on when they're discharged, knowing what to do when they have palpitations, and knowing when to contact their cardiologist about them, and to know when to follow up with their cardiology. So there's a lot more education that we're going to be doing until they can get cardioverted in the morning. The third example that I have for my staff is a 35-year-old patient, alert and oriented from home, walkie-talkie, admitted with a UTI. The patient's been afebrile for 24 hours. They've been receiving antibiotics, and their white blood cell is trending down. They're placed currently on 4 liters nasal cannula with an SpO2 of 91%. They're receiving Levophed at 6 mics, and their blood pressure is currently 100 over 70. Are we going to allow this patient out of bed? Yes, we will. This patient will be allowed to get out of bed to a chair. They're only on 1 pressor. They're afebrile, and their oxygen, the oxygen they're receiving is less than 70%. Once we go over these examples and I give feedback to my staff, this is expected to take 4 minutes of my time. I'm hopeful that my staff will be very engaging in comments and questions during these examples. The third objective that I have for my staff is that they will be able to identify the signing that we're going to be using. And the signage that my committee has decided to use is a stoplight. And the criteria for that is, if you are a red light, we're going to hang a red light on your door. And this means that a patient's unable to bear weight on one or both legs, or they are bed rest. So they'll be a total assist. A yellow light on your door means that you either need an assistive device or the patient is a one or more person assist, meaning that they can bear weight for a little while, but they will not be able to tolerate full weight bearing for long periods of time. To have a green light on your door, you need to be a complete ambulatory walkie-talkie from home or an assisted living, a nursing home. Those are patients that will receive green lights. The nurse may be at the bedside to unattach from cardiac monitoring or the blood pressure cuff, but the patient will be allowed to ambulate on their own. I'm going to go over with my staff that they will have this handout that I have shown again. They'll know the objectives of my project, that it was for our patients to be out of bed sooner and to decrease the deconditioning that our patients have been receiving. I'm going to explain to my staff that it is not unreasonable for me and management and administration to ask these things. As I have currently been doing them, we have other nurses who have currently been getting our patients out of bed. It's within our scope, so not only are we allowed to do it, but we're expected to do it as nurses. That we need to prevent deconditioning and do what's best for our patients, which is getting them back to their home environment, whatever that is, be it their home or assisted living or a nursing home. We're there to help them get better sooner. Upon assessment of this, administration will decide how successful ambulation for our patients are. And if they see that our efforts have been helpful, and they are going to consider placing this on the critical care work list, not only at BARH, but as a system-wide assessment for all 13 ARH hospitals. And this will minimally affect our workload, as within the past year we've taken on a lot because we went to electronic charting, which was a big pushback from our staff. But on the next schedule, every shift will have one clinical nurse manager, one on days and one on nights for every shift. We've recently hired 2 new, we call them CNMs. And so every shift will have an extra set of hands. And we're a team. We've been a team. We've proved time and time again that together as a team, we make one great nurse. So we will do it together. If you need help, just like any other time, you can come to me and I'll always help you get your patient out of bed. I'll help you turn them. But I'm not asking you to do this on our own. The thing that I'm asking, though, is that our patients be out of bed before 12 o'clock for lunch, and that they stay out of bed for at least 45 minutes. I don't feel like that's unreasonable. If a patient wants to go back to bed before 45 minutes, that's fine, because a lot of times patients have been in the hospital and they are very tired, and it's a very disruptive environment compared to what they're used to at home, and they need to rest when they can. But my goal is to have them out of bed before lunchtime for at least 45 minutes, especially if we know their doctor's been around, because if their doctor sees them out of bed, that has proven to me multiple times in the past that the doctor sees that the patient is improving. My administration has my back. My management has my back. Many of my staff already have my back throughout this project. And this is all the objectives that I have for my in-service. But based on the feedback that I received from you, I'm going to allot a couple minutes for questions and feedback from my staff. While this happens, maybe they'll bring up some things that I hadn't thought of in the past, and before our go live date, we'll be able to incorporate that or address their concerns. Even one-on-one, I'll bring it to my committee and see what they say. I'll bring it to my administration and see what they say. But I want my staff to know that their concerns and comments matter to me. And if there's a problem, that they can talk to me about it. And I don't really have anything else. I will provide a snack for my in-service, both on days and nights. But that's all that I have. Thank you so much.